Good evening, everyone. Thank you very much for joining us. We really do appreciate you coming along to these events. Um, for those who don't know me, my name's Simon Clark. I'm the Technical Product Manager for Cats, Dogs and Horses at Verbeck. So I'm the person to contact for marketing questions, for product technical support, any of those questions. You're welcome to email me, you're welcome to phone me. I love talking about cases. I get curly questions all the time and it's great fun. Tonight we're talking about dental extractions, and I just wanted to introduce the Verbeck dental range a little bit first of all. Three lines in our dental range. We've got the CET toothpaste and dental kits. We've got the Vigident chews, which have been recently upgraded with fresh technology, and we've just relaunched Aquadent. So Aquadent was out of the market for 18 months, 2 years or so, and it's been completely reformulated and relaunched, and we'll talk about that in just a minute. The first thing I want to talk about a little bit is the recently released WISAVA dental guidelines. A lot of you will be very familiar with the WISAVA vaccine guidelines, but they have guidelines for a whole lot of diseases and illnesses and areas of management. This is the second dental guidelines that WISAVA has released, and there were a couple of things that I wanted to sort of emphasize. So as we are well aware, after a COHAT, a comprehensive oral health assessment and treatment, plaque will develop again within 24 hours, and that plaque's going to turn into tartar 72 hours after that. So even if we have our patients come in and get a thorough COHAT twice a year, periodontitis is going to continue to progress. We're going to have tooth pain, we're going to have tooth loss, and all the things associated with that. Home care is essential, and they've always emphasized that. But the changes, while previously they've said you must brush and there's no compromise associated with that, they recognize that toothbrushing is the gold standard of home care, that is not easy for everyone. So we have what we believe is a very palatable toothpaste. I haven't tasted it myself, but my dog certainly enjoyed it. And the flavoring is all about the encouragement and reward, and to try and get these pets to tolerate having their teeth brushed. And as a lot of us know, cats and dogs can get used to all sorts of things. We'll know that pets that need pills regularly very quickly get very good at taking pills, and with a bit of routine toothbrushing, even the very set in their way dogs and cats do actually start to tolerate toothbrushing with a bit of patience. So toothbrushing is the gold standard, and we've got excellent toothbrush and toothpaste to help with that. But the difference between this dental global guidelines and the previous one is the recognition that only 5% of clients that are advised to have their dog's teeth brushed continue to do so at a frequency that's useful, by which we mean more often than every 3 days. Because if you're doing it less often than that, we're not actually going to slow down the progression of tartar buildup. So a compromise is necessary, and they've recognized that, saying we really want you to do toothbrushing, but if you alternate between toothbrushing and using a dental chew, even though that is a compromise in quality because toothbrushing is superior to chew treats, you have a great increase in compliance, and therefore we're actually going to make some progress and actually help these animals. So if we can get 5% of our clients to do toothbrushing 2-3 times a week, that's fantastic. But for the other 95, we might need to talk about a compromise that will allow better compliance at home. And so that's where the Vigident chews come in. So they now recommend a combination of toothbrushing and dental chews to get that balance of compliance and efficacy. Compared with other chews, we have excellent palatability, so the prehension rates and the total consumption rates are pretty much the same as our competitors. They're all very, very tasty chews, but we're able to do that with a meat-free formulation. The flavoring comes from brewer's yeast. Ours is a completely meat-free, fat-free chew. So this way it's low calorie, it's suitable for diabetics, it's suitable for animals that have dietary restrictions, it's suitable for animals that have previously had liver disease, it's suitable for animals that are trying to manage their weight. So it's a good option because of that entirely vegetable based matrix. But that's always been the case with VeggieDents, but we've enhanced them with fresh technology, and here we're talking about Aquadent and VeggieDent simultaneously. So there's three ingredients that make up fresh technology. The first of them is pomegranate. The idea here is that this is going to limit bacterial development in the mouth and change the nature of the flora in the mouth to help slow down the progression of plaque and tartar. And we've got several published studies demonstrating that these ingredients individually have excellent effects, and in combination in the actual product have objectively demonstrable effects, and that client perception is really high for this product as well. The second ingredient in the fresh technology is erythritol. This is for a sort of minty fresh effect, but it also helps control bacterial growth in the mouth. And we've got studies that demonstrate all of this as well. I'm rushing through this because this isn't the point tonight, but I'd be very happy to come to your clinic and discuss this at length. Talk to your area sales manager about getting this booked in. I'll be very happy to come and talk to all of you. The third of the ingredients in VeggieDent and the fresh technology is inulin, and this is what we euphemistically refer to as non-oral causes of bad breath. We're talking about the intestinal smells, belches and farts and so on, that can impair the close bond between a pet and their owner. So it's a prebiotic that's going to help reduce foul-smelling gases. And we've got published studies that show that we've got good efficacy with this as well. Cadaverine and spermine were measured. These are the breakdown amines that have those really sort of pungent, foul smells. Concentrations of phenols were in the feces were demonstrated to be substantially lower as well. So we've got digestive causes of halitosis. We've got management of the oral flora. We've got a cooling effect. So all three of these together have a great breath freshening effect. We've also got published studies showing that, so those studies that I showed there were about the efficacy of the individual ingredients, but we've also got studies showing that we've got high palatability, high safety, high efficacy of the finished product for both VeggieDent and for Aquadent. We've got really high client appreciation that they enjoy the effects of these products. And in Aquadent, so this is completely reformulated from Aquadent original. It doesn't have any chlorhexidine and it doesn't have any xylitol. And we've got excellent safety studies on that finished product there. So if you do have any questions about our CET toothpaste, the VeggieDent now enhanced with fresh, the new formulation of Aquadent with fresh technology, please do feel free to get in touch with me or with your area sales manager. We can come in and do a clinic training, or we can give you some support material to discuss that. So that's all from me. I do want to introduce Crystal. For those of you who don't know Crystal, she's currently doing residency training to become a specialist in dental work. She's working with David Clark, learning some amazing things, doing some excellent procedures, and we are very appreciative that Crystal's joining us tonight to talk us through avoiding complications of dental extractions.
Excellent. Thanks, Simon. So do we pull the presentation up now?
Yes. Sorry.
All right. Can everyone see that? Hoping so. Thank you very much for having me here today. This is my first webinar, so I'm really looking forward to this experience. I was kind of hoping to roll through it incognito, but Simon says that you guys like to have a live video feed so you can see what's going on. So here we are. You can see me give a thumbs up and okay. If you have anything, just say something, and I'll try and have a look in the chat. But most of the questions, if we can, just hold till later, so that I can get through all the material. So yeah, just wanted to talk about avoiding extraction complications. I think we've all experienced this at one time or another. So it's just a disclaimer, but this isn't going to be a step-by-step on how to do extractions. But we are going to talk about what complications can happen, how to plan for them, and hopefully I can give you a few practical tips on how to have successful extractions in your daily practice. So when I first started putting it together, I kind of looked at the definition of complications. So I like to look at all the definitions to get myself started. And of course, we know there's a medical definition, which is a secondary disease state aggravating an already existing one. And then there's two other definitions, which is state of involvement or confusion, or a difficulty, which I think at any given point, we've probably experienced all of these things. It can be aggravating and confusing and difficult all at once. So I thought I'd start with a case that we saw last year. So this one was really interesting for me, and it was a huge learning experience. Sorry about the picture of the vulture at the bottom. So everyone who's kind of seen this slide is like, that's not a dog, but it's actually about a dog, which is a 13-year-old male intact Maltese cross. His name's Copito. He hasn't been to a vet in several years, and the owners have brought him in because he's got matted hair around his eyes. He's very snappy, very resentful about having his face examined. You can't look in his mouth at all, but he is in quite a bad way. So we decided to get him in and get him under general due to his age, and investigate everything further. And certainly he had purulent discharge from his eyes and things like that. So we needed to clip the hair around the eyes and try and find out what was going on. So of course, once he's in the hospital, getting ready to be anesthetized, he has terrible halitosis. And, I know New Zealand has lots of really cool colloquialisms, but here's one that I really enjoyed from my North American heritage, which is his breath was bad enough to knock a vulture off a meat wagon. So that's why we've got the vulture in the corner. It was just to sort of illustrate that colloquialism. But anyway, so this is Copito. He, once we get him down for induction of anesthetic, it's very obvious that he's suffering from very severe dental disease. So he's got many problems. One is he's got a huge oronasal fistula on the right-hand side where the maxillary canine used to be. His remaining teeth are all extremely diseased. He's got really severe calculus buildup in those the caudal cheek teeth. And the reason why he presented with matted hair was because he hasn't been able to close his mouth for a very long time because of how severe the calculus is. And on the external examination, he's actually got quite severe wastage of the masseter muscles. He's got a prominent zygomatic arch, and that calculus is so thick it's causing an outpouching of the skin that's causing the hair to poke into his eyes and cause cause corneal ulceration and discharge. So he's been dealing with this for a very long time. The poor dog's been in a state of pain for a long time as well. So it's now our job to try and restore some quality of life for him. And you can see on the left mandibular molar as well here, there's really thick purulent discharge emanating from around the tooth. So the first few teeth do come out really easily. They're the ones that just sort of fall off. We've got a specialist anesthetist, and she likes to say that this is when she leaves her specialty and forays into dentistry, because this is the anesthetist extraction, because when she puts the tube in, the teeth basically fall out. But those are only a few teeth. The rest of them are a lot more involved. We took full mouth x-rays of Capito's mouth, and the most obvious problems were on the mandible. So this is the first part, which is a rostral mandible that we're looking at. And, from first glance, you can see there's a few things. There's teeth that have just remnants left. There's a lot of missing teeth. The bone's quite diseased looking, evidence of osteomyelitis. There's this premolar sort of floating in space, and it's not supported by any bone. The rostral incisors, whichever ones are left, also have advanced disease. But most surprising and probably most interesting is that the entire mandibular bone is really, really thin. So if you were to look at the width of the canine tooth in this instance and compare it to the width of the mandibular bone in certain areas, those canine teeth are actually wider than what his mandible is on a direct parallel view. So that is an indication of how severe this disease process is. Not only that, as you can see at the apex of these canine teeth, there is very little bone surrounding them too. So this dog's at real risk of fracturing his jaw if we try and extract these canine teeth. The other thing that is really interesting as well, and quite sad with Copito, again, is the advanced periodontal disease in the caudal mandible. So it is really remarkable how bad this dog's teeth were. And these teeth are ones that you would think would just exfoliate really readily. You would think that you'd be able to pull them out really easily. But the reality is, when you look at the anatomy of these teeth, they may be very severely diseased, but they're not falling out for a reason. And the reason with these teeth, it's because they have got root dilaceration, which means that there's hooks on the back of these teeth. And they are being held in place by a small shelf of alveolar bone. The other thing to take quite a serious note of is that the ventral mandibular cortex is no longer fully intact. These mesial roots are actually being held in place by a bone callus, because there is bone remodeling going on with the advanced periodontal disease. So you look at this and you think, well, what could possibly go wrong? There's so many things that could go wrong, but this dog's at a very, very high risk of fracturing his jaw, especially if we just say try and pull on these teeth without actually elevating them until they are fully loose and ready to go out. So this is just an example of the case where there's a lot of periodontal disease present, but we need to be really, really careful in how we plan to take these teeth out so as not to cause something that will be detrimental to the patient. Okay, so his teeth did actually come out. We sectioned a few. You can see the extent of the disease that's there. But again, careful planning can avoid a lot of heartache. And Capito is doing very well now. He's acting 10 years younger, the owner said. And he's gone on to live a happy life. So let's talk about extraction complications now. This slide's just extremely busy on purpose, and it's intentionally busy just so that you can see all the different things that can happen. And, just looking at this slide does also incur that sort of feeling that the little painting does for me. It's like, oh my gosh, I don't want any of these complications to happen to me. But the reality is most of them will happen to us at some stage. But I do want to just draw your attention to this one on the left-hand side, which is orbital trauma. So I did quite a bit of research for this talk, and in one of my literature searches, I came across 3 articles about orbital trauma. I've got them here. If you feel like reading them, they're actually really interesting, and they will strike the fear of God into you about doing extractions. But I only put them up here because it is really interesting to know what the worst case scenario is that could happen. For example, in this 2003 paper in the Journal of Veterinary Dentistry, there was 3 cats and 2 dogs that had ophthalmologic complications associated with tooth extractions. And one of the worst ones was a tiny little dog that actually had a penetrating injury to the cranial vault, and it did die from a brain abscess, which again is terrifying. But like I said, it is, this is just worst case scenario, and it is good to know what can happen so that we proceed with caution. So what are the top 5 extraction complications that we actually encounter? So aside from the nightmare of potentially poking them in the eye, so the most common one probably that we encounter is root fractures, and that is that annoying crack that you hear when you're trying to pull the tooth out, and then you think, oh, great. So then you have the issue of trying to retrieve that root fragment, which we will talk about later. But the biggest thing is that we want to try and avoid root fractures, not only because they can be more traumatic to the patient, but also because they do add a lot of time to our surgery, especially if we're sort of fossicking around trying to find that root. The other thing that can happen is root tip displacement. And you may or may not have experienced this. I have experienced this several times myself. So what often happens is you have a periodontally diseased tooth, or you're using an inappropriate technique, and you may accidentally push the root tip fragment down into the mandibular canal, most commonly, or upwards into the maxillary sinus, and that tends to happen with the palatal root of the upper 4th premolar, mainly because the shelf of bone that's covering that is very small. So if you're poking around in there, it's usually very difficult to visualize if you've broken the palatal root off. So that is a danger of displacing that root fragment. Thirdly, we can get hemorrhage, which I'm sure, again, we've all experienced hemorrhage with tooth extractions. So it's very, very common, this one. And, most hemorrhage, well, pretty much all hemorrhage will stop with pressure, as long as there's no sort of complicating systemic reasons for coagulopathies. And this picture here on the right just demonstrates just how close some of those blood vessels can be lying. So this is in a small breed dog. It's a little teacup Yorkie. And this is a first mandibular molar that's been sectioned, and the distal root has come out. And that distal root was quite diseased. So that little white area here that you see looking directly down into the alveolus is actually the mandibular nerve with the blood vessels running just along there. So had we been a little bit too aggressive or forceful with our luxation, then we could have very easily lacerated those blood vessels and created a bit of a problem for ourselves. So that can happen. The other thing that we often see is flap dehiscence and breakdown. In worst case scenarios with these ones, we can have oronasal fistula formation, which is quite common with the long-nosed breeds, the dolichocephalics, like Dachshunds and Greyhounds. So these are flaps that usually are under a lot of tension, or the patient has been very bad at complying with postoperative care, and the flaps broken down within that first couple of weeks of healing, postoperative healing. So oronasal fistulas occur if you have very, very periodontally diseased teeth, particularly in those maxillary canine teeth with those dolichocephalic breeds, and they can become a chronic problem. So lastly, probably the last extraction complication that I wanted to mention in particular is iatrogenic jaw fracture, and that is probably one of our top nightmares when we're doing extraction complications, aside from now orbital penetration, which is also one of my top nightmares after reading those papers. But certainly, that's worst case scenario, is actually causing a jaw fracture without intending to in our patients. So when do extraction complications occur? This is kind of, this slide is just thinking about how a lot of my complications have occurred over the 12 years that I've been practicing. I think it's been 12 years now. But one of the things that that I tend to find is that most of the complications occur if there isn't proper planning in place. So, for example, you haven't correctly gauged the extent of disease, or you haven't defined what really needs to be done, or you've underestimated the type of work that you've done that needs to be done. We haven't, prepared ourselves. We haven't prepared our team. We haven't prepared our clients on what might happen and what we might need to do. And that is all tied up with also, how we select our cases and things. We may not have the right equipment to perform the procedures that we want to do, but we think, we'll give it a go anyways. We may not have the right technique to be able to do those procedures. But probably the biggest thing that causes complications is our own stress. So a lot of it can be, say you're trying to do the extractions and you've got 3 other people talking to you at once. Somebody's on the phone about so-and-so wanting a repeat script, and someone's at the front wanting something. It can be very difficult, especially if, say, you only have a block of time, you're meant to do consults soon, and you've suddenly got all these unexpected things that have come up. So that stress just adds to the likelihood that you're going to cause more issues for yourself. So the other things that do influence it are follow-ups. So any animals that are lost to follow-up, sometimes through no fault of our own, they can come back with post-operative complications. And then finally, regardless of everything that we try and do, we could do everything perfectly right, and once they walk out that door, we have no control over what ends up happening. So we know that best intentions or best laid plans, but still sometimes, no matter what we do, you're going to have a complication because of the owner or the patient. So what happens, this is just a little slide. I tell myself when a complication happens, I breathe. If I have someone to ask for help, I'll ask them for help. Sometimes having another perspective is good. I'll try a different approach. But, if whatever I'm trying is not working, or I'm going to make it worse for my patient, then it is perfectly fine to stop. You can stitch that animal up or send it, wake it up and send it somewhere where it can be fixed, or, have another try later on when you're more in the zone to be able to cope with that. The other thing is I always try and learn from each case, and I have to remember, we're all type A personalities, or a lot of us are at least, and we tend to beat ourselves up a lot, like probably every day on a daily basis. If I mean, I know I do, but we have to remind ourselves that complications happen to everyone, like literally everyone. You know, it doesn't matter if you're a specialist or you're a new grad, you will have a complication of some kind, and it's just how we deal with it that, you know, will be the best to help our own mental stress and things like that. So when it comes to planning for extractions, in the past, we used to always call them dentals or, you know, dental surgeries. I booked myself 3 dentals. We're trying to steer away from that now, especially like as a dental guideline say, they've mentioned this thing called a COHAT, which is a comprehensive oral health assessment and treatment. So the reason why I try to steer away from you know, the term dental is because I feel that you know, we've found that over time it just doesn't truly describe what you need to do, and it doesn't give enough value to what you're actually doing as well. So just to illustrate this point, I just want to show you the dental charting system that we use here. So this was developed by David, and there's quite a lot of features with it, and it takes a little time to get used to. But after having used it for a year, I do think it really gives a lot of value to this actual COHAT thing. You know, on the left-hand side is a pathology chart. On the right-hand side is a treatment chart. So you have got every single tooth has an individual pathology written for it, and likewise, it's got the corresponding treatment, and it basically reinforces that, you know, especially to you, your team, and your clients, that with every dental that you're doing, you are actually making 42 separate diagnoses. So, you know, you want to make sure that you are planning properly, so that you can affect the best treatment plan for your patients. The other thing too is, again, make sure that your clients are on board with everything. You know, that can make your job more difficult if you haven't you know, communicated to your clients appropriately. Do they want to save the teeth? You know, do they know the implications of extractions and the post-op care that's needed for the procedures? Do they know what's going to happen long term if they their dogs, say, lose principal teeth and things like that? And then on the day, you want to make sure that they are contactable. You know, because if you do find something different, you know, what do they want you to do? Do they have cost limitations? Do they have certain expectations around things? And are they happy for you to do a staged procedure? And in some instances, you know, whether it's a time constraint or you make that decision on the individual patient, it is better to actually perform the COHAT and make the diagnoses first, and then get them back in for a second procedure and complete anything else that you need to complete. The other thing is also give yourself time to do the work. You know, I have worked in sole charge practices, and I have also worked with multi-vet practices. And, you know, it is very difficult if you're consulting and doing surgeries at the same time, or consulting, doing surgeries on the same day. So it's dependent on your practice and what your setup is. But we found that we love dentistry days, and that's the days that we just do dentistry on. And, you know, when I was in general practice, I had dentistry days as well. You know, you can consult in the morning and then go roll into surgeries, because I found that the hardest thing is when you have consults in the afternoon that you're trying to complete your surgeries by. So it's better to do the consults in the morning, and then you have an open end towards the day, just to give yourself time to do the work. The other thing is, how many surgeries do you book? And that is dependent on, you know, how well you can plan for your surgeries. Do you have sufficient staff numbers? And, you know, with that regard, I would say that I'm always very positive, and I'm sure my nurses that have worked with me before will say that Crystal always overestimates her time capabilities. So, you know, you get that one nurse who's really good at booking and who's like a Nazi about it all. And yeah, listen to her, because usually you end up running out of time and putting more pressure on yourself if you overbook yourself. And the other thing is, if you haven't got a trained dental nurse or several in your practice, then I would highly suggest that. I've been very, very fortunate to work with some wonderful, passionate girls and guys about dentistry, and a trained dental support staff member who can chart, who can radiograph, and who can do the scale and polishes is completely invaluable in terms of time and efficiency, and helping you do the work, and also plan for the unexpected if you can. So when you talk about individual tooth features, there are a few things to consider. So when we're looking at the type of tooth to extract, it does depend on a few things. One of them is it a deciduous tooth or is it a permanent tooth? So with deciduous teeth, if we're having to extract them because of, say, a fracture, like in this situation up at the top, some of the factors to bear in mind are these are teeth that are very fragile. They've got wide pulp chambers and very thin dentinal walls, so they are prone to fracture. And then also directly underlying them are the adult tooth buds that are forming. So if we happen to traumatize that area too much, then we have to bear in mind that there is a possibility that we can traumatize the crown of those teeth. So we do want to try and avoid that. It is worthwhile to mention to the client that is a potential complication that could happen with the adult tooth bud. But that is one of the features to keep in mind. They're in close proximity to those adult tooth buds. The other thing is when we have a persistent deciduous tooth, then quite often you have these teeth are in a partial state of resorption. So, for example, and this is from pressure from the adjacent adult tooth. So, for example, in this picture here, again, dental radiographs are invaluable. You can see that the dentinal walls thin just where it's lying adjacent to this adult crown. So if we're elevating along this tooth, then we want to be careful to avoid fracture at that point, which is the weakest point. This is just a wee dog that we saw that has had some trauma to the adult tooth bud when a deciduous canine tooth came out. And it's just an example of, again, worst case scenario of what potentially could happen. So the adult tooth has now erupted with very disrupted enamel. And because of that, the enamel is not quite so protective to the tooth, and bacteria has been able to migrate through into the pulp chamber, and that's ended up causing a pulpitis, an irreversible pulpitis, and the pulp has unfortunately died within that tooth, and it's created a draining sinus through an abscess at the base of the tooth, and that's appearing as a chronic non-healing wound under the dog's mandible. So again, this is one of the examples of what can happen if we're not careful with our deciduous teeth extractions. The other thing to consider is also whether it's a principal or strategic tooth. And by principal or strategic tooth, we mean either the canine or carnassial teeth, and the reason why these are called principal or strategic teeth are because they provide a lot of structure to the dog's face or cat's face, and they are also the most functional teeth in the animal's mouth. So extraction and loss of these can have some consequences. So, for example, with the mandibular canine teeth, this little dog on the left-hand side is a good example. Is if that lower canine tooth is gone, the tongue no longer is held straight in the mouth. It's kind of falls to the side. It can be an aesthetic thing, but it can also lead to dermatitis on the side of the mouth, and some owners just don't like the look of that. The other thing that can happen is like with this one on the right-hand side, where the upper maxillary tooth has been extracted, and it's caused that upper lip to fall in and get entrapped by the lower canine tooth. And it's on both sides. And as a result, this dog's the way whenever he licks his tongue, he's causing excessive salivation around that muzzle, and you can see all the salivary staining that's occurring there. Okay, and then the other thing is also with the carnassial tooth, one of the big chewing teeth. Once that's gone, then you have no contralateral tooth to chew against, so it does affect how the animal will chew on that side. So these are all conversations that we have with the clients before we discuss extraction. The other thing to consider is also the degree of periodontal compromise. So there's Copito on the bottom. Again, he's in an advanced periodontal compromise, so it'd be very difficult to save those teeth. In fact, impossible. But then you have another scenario like this dog here, where there is periodontal disease. You can see that evidenced by this widened periodontal ligament and evidence of some bone loss along the distal root of this molar, and that is caused by crowding with the adjacent molar tooth here, causing food debris to track down and plaque to track subgingivally. So in circumstances like this, you've got two periodontally diseased teeth, and it may make more sense to remove a non-strategic tooth, such as this little molar, and then potentially perform a root planing procedure on that distal root in order to preserve the principal tooth, which is the molar tooth that would affect how the animal chews and things. So again, a degree of periodontal compromise is something else to keep in mind when you're planning for extractions. So just because they've got periodontal disease doesn't necessarily mean that tooth has to come out. We can be strategic about that. The other thing to consider is type of pathology that's present, and tooth resorptions are something that we see very commonly. I've got a dog up here because it tends to be a little bit less common than what we see in cats, but again, you look at the tooth structures, particularly on X-ray. This one's got severe advanced tooth resorption, and the roots have almost been eroded away, and they've been resorbed by the bone quite a lot. So if we were trying to extract that, it'd be really difficult. So that's a tooth that we would do what's called a crown amputation on. And that's what's happened in the right-hand side, where we remove that coronal portion and then smoothed out the bone and stitched the gum over top, because it would be impossible to actually extract those teeth, those tooth roots. On the other hand, this one also has another type of tooth resorption, is internal tooth resorption, and it also has evidence of an endodontic lesion, whereby the bacteria has traveled into the pulp chamber through that resorptive lesion, and bacteria has now dribbled out the ends of both the tooth roots. And this tooth here, however, when you look at it, has an intact periodontal ligament around the whole tooth, which means that despite it having a tooth resorptive lesion, that tooth does need to be surgically extracted in full. We can't do a crown amputation on that. So again, another thing to keep in mind. Lastly, when you're planning, another thing to think about too is, are there alternative treatment options for saving teeth? And if you're unable to do it, is there somebody that you can refer to who can perform an alternative treatment on the tooth to try and save it? So this is a cool case that we had this year. Again, I've seen so much cool stuff during my residency, and I really like this one. And this one was a little teacup Yorkshire Terrier who was about, I think, 1.6 kilograms. Very small, and again, he's got periodontal disease, and the distal root of his molar is very diseased with bone loss. In fact, he was the one where I showed you earlier. You could see the mandibular nerve and the blood vessels running through the canal. So with him, we decided that because his jaw was very thin, we didn't want to compromise the integrity of it any further by also removing the relatively healthy mesial root. So this mesial root here had hardly any pocketing. It's still got a lot of bone around the majority of its root. So to take that out, we would have had to do a surgical extraction and actually remove bone. So again, that would have compromised the integrity. So what we did was a hemisection. and a pulp capping, which kind of gives him this funny looking tooth. It's still functional. It's still stable. This is him 4 months later, and the pulp capping has been successful, and he gets to retain that little mesial root and also retains the structure to the jaw in that region. So again, these are some of the alternatives that can be done. And if the owners are keen to commit to saving the teeth, then it's definitely worthwhile doing. Some of the extraction tools that you may need. So these are the tools that we use. This is our usual extraction setup. We've got our little perio kit down in the left-hand side with all our pretty colored curettes and probes. And then above, we've got our extraction kits. So we use Sislac, which is a American brand, and they are definitely the top quality dental instruments that I have used in my career. I have to say that they are really, really, really good. So I highly recommend Sislac. We've got a range of the different luxator types. We've got our extraction forceps. We've also got 2 different types of periosteal elevators, a large one and a small one for the cat extractions and smaller dogs. And actually, we use the small one most commonly. And there's also deciduous teeth elevators there. So the deciduous teeth elevators, I'm not sure if you can see, but they have a special curve on the on either side of them, and they are actually specifically designed for deciduous tooth extractions, and they are very useful as well when it comes to taking out those deciduous teeth. The biggest thing with the elevators and the instruments is make sure they are sharp. So if you've got a very savvy dental nurse or nurse in general who loves to sharpen instruments, then take advantage of that because you are more likely to have more problems and cause more damage if you are using dull instruments. And I know this from past experience where I've used instruments that have probably not been sharpened in about 20 years. It certainly makes the job a lot more difficult than if you have nice sharp ones. You should also have a variety of burrs and a stitch kit. And inside your stitch kit, they should be nice and fine instruments, like a nice pair of iris scissors to that you can undermine the periosteum with, and also nice fine needle drivers to help you get into those tricky spaces as well. So dental radiography, I know not all of us have it. Put it on your wish list if you haven't got it yet. Dental radiography is the gold standard for accurate diagnosis and planning. I say gold standard in general practice. Now in America and things like that, you have things like cone beam CT that probably won't be readily available in general practice, but certainly, yes, dental radiography will change your life. So there are 2 systems, DR and CR. Both are pretty good. We quite like the DR system just because of how fast it is and the quality of the image. There are many uses for dental radiography, not just in diagnosis and things like that, but certainly you have a huge use out of them with pre and post extraction radiographs, and especially say in the particular case of refractory stomatitis cats. So these are the ones that do usually end up needing full mouth extractions. We know that those ones, if we leave any tooth remnants behind, we won't get cessation of clinical signs. So this little dude up at the front, he's a little cat that I saw several years ago, and he had stomatitis for a good 3 years. He'd had full mouth extractions after a year of trying to control his clinical signs. And then he continued to have symptoms and had been given steroid injections over the course of 2 years. When I saw him, we did full mouth x-rays on his mouth, and we found 9 retained tooth roots. So we extracted all of those tooth roots and removed any sort of diseased bone associated with it. And here he is sort of 9 months down the track, and he's got no inflammation in his mouth, and he's very, very happy. So again, couldn't have done it without dental radiography. So here are this is just a handful of cases where dental radiography can be useful. So diagnosing tooth resorptive lesions, similar to the dog that I showed you before. So again, externally it doesn't look so bad, but then when you take the x-ray, you can see that this is a type 2 tooth resorption and the roots are ankylosed. So again, that tooth would be treated with a crown amputation rather than a extraction. It can save yourself a lot of time. And then this is another one. There's a little tooth that was diagnosed with a periodontal pocket, and it did need to be extracted. On the X-ray, you see that there's evidence of root resorption. So again, another one to be very careful of, because as you're elevating, if you put pressure on that spot too soon, then it's liable to fracture in that location. This was another little guy that I saw a few years ago, and he's got terrible teeth. Pretty much all of his teeth are bad, and when you initially look at it from the outside, you think, oh yeah, they are so periodontally diseased, they should be relatively easy to extract. But then when you take the x-rays, it's a totally different story. Under all of that calculus, these teeth are in advanced stages of root resorption. Not only do they have all these weak points where the crowns are going to fracture, but the other thing is that whilst he has intact periodontal ligament around all of these roots, meaning you have to extract all of them, they've also got this round sort of bulge on the end. They've all sort of got a bulbous appearance, and that is most likely from hypercementosis, which is excessive cementum being laid down in response to chronic inflammation. So that does make those teeth a little bit more difficult to extract. And this case in particular ended up all being surgical extractions. So he did need a flap raised and all those roots removed individually. And then another little sort of curiosity is supernumerary roots of the upper premolar on cats. So this is the 107 and 207. So a small percentage of these cats, I think it's about 10-15%, have a supernumerary tooth root. So rather than being a double-rooted tooth, they've actually got 3 roots to them. So if you do not know that there's a third root there, then you may leave one behind, which is what happened on the other side from a previous extraction. So going on to doing extractions. So when you're planning to do extractions, you do want to make sure that you know what type of extraction you're going to perform. And there are several. So there's simple or closed extractions, and there's also open or surgical extractions. So with your simple or closed extraction, you're not raising a periosteal membrane flap. These are ones that usually are reserved for single-rooted teeth like the incisors, or quite advanced periodontally diseased teeth that have very little bony attachment. But even in those circumstances, if they're multi-rooted teeth, we would recommend still sectioning them and taking them out one by one. But yes, this is a simple closed extraction. We have no mucous membrane flap raised. Again, this is closed extraction as well, but this is with multi-rooted teeth and it's with sectioning. So this is I just wanted to mention this, which was a little tip that I picked up along the way that I found really useful. So particularly these maxillary molar teeth. These are 3-rooted teeth that tend to have very slender roots that often the tips break when you're trying to extract them. And in the past, what I used to do was section that tooth completely and then remove the buccal roots first and then the palatal root. But what I've been taught now, which has been really, really helpful and valuable, is that most of the disease tends to be on those buccal roots. And so when you section them here and take those out, it makes the palatal root a little bit more tricky to take out. So what you can do a section between the buccal roots and the palatal root, and remove that first. And because then you have a stronger structure to, say, elevate against, and then section the buccal roots separately once that palatal root is out, and then it'll just be easier to take those roots out without potentially fracturing them as well. So that's one little pearl of wisdom that I've picked up over the years. So when we're considering your surgical extractions, this is where you have to raise a mucoperiosteal membrane flap. So of course, there are a whole bunch of different flap designs, and you just want to make sure you pick one that's going to allow you the most visualization for what you need to do. So on the left-hand side, there's an envelope flap, which is basically you're making gingival sulcular incisions and raising a little flap that's like a little envelope like that, and you have no vertical releasing incisions. On the right-hand side, there's a pedicle flap, and that's where you're making two releasing incisions. You can also do triangle flaps where there's only one releasing incisions. But again, whichever one you pick is best for visualization, or that you're most comfortable with, is the one that you want to do. The envelope flaps can be very useful in terms of a faster closure, because you may only need to do a few sutures interdentally, but again, you want to be able to visualize the tooth appropriately, and if you can't get enough visualization with the envelope flap, then you can do a pedicle flap or a triangle one. So once you've raised your flap, then you're looking at how much bone do you remove? And that is something that we get asked a lot, is how much bone is safe to remove around a tooth before I can extract it. And the reality is that the likelihood is that it's all individually dependent on the tooth and its periodontal health. So how I was taught by David was to visualize the alveolus, or the socket, as a box with four sides. So if all four sides of that box are intact, then you can safely remove the majority of one side of that box. However, if you have got compromise to all four sides, or say two sides or something like that, then that may change how much bone you can safely remove on the side that you're wanting to remove that tooth on. So I guess the final say on that would be that it's a judicious removal of bone, dependent on the periodontal health of the tooth. You want to be able to remove enough to extract that tooth, but not enough so that you compromise the integrity of the jaw. So just judicious removal of bone at this stage. The other thing is you do want to use appropriately sized tools. So do not use small elevators, very, very small elevators, to try and elevate a large tooth root, because you're more likely to break the instrument and not get anywhere. But yeah, just use appropriately sized tools. The other thing is also to support the jaw on the side that you're opposite to the side that you're elevating with, and providing that support to the jaw will make sure that when you're elevating, there's not excessive pressure on it. You should be able to support that with your hand. Make sure that you're cutting and tearing the periodontal ligament well, and placing them in a good position so that there's no slippage or breakage. You can make little troughs around the tooth roots so that it allows you to seat the instruments alongside the periodontal ligament better. And probably the key point is to do not try to attempt to remove the tooth too soon, because if you're trying to remove it too soon, then and it's still very tight in the alveolus, then you haven't released or stretched the periodontal ligament enough, and you're more likely to leave parts of the tooth behind. So another important thing is, which I've learned even more so this year, is don't rock the tooth in the alveolus. So my hands are really flexible and my wrists are really flexible, and I've learned not to be too bendy with my wrists, but to use a force that so I'm not sure if you can see it, but I'm rotating around my forearm rather than rotating around my wrist. When you're rotating around the wrist, you're more likely to rock the tooth in the alveolus, and when you're rocking it back and forth is when you're going to put pressure on the tip and break it. So what you want to do is rotate it around the long axis of the tooth. So rotate it around the long axis of the tooth. And as you're doing that, you can either push it for a little bit and compress the periodontal ligament and then pull, or just steady pressure and rotate it while you're pulling. Okay, and you'll have a bit more success delivering it from the alveolus that way. But when you're doing this as well, you do need to consider the different root anatomies of the different teeth. So some teeth are more ovoid in shape, which will determine how you can rotate them around the long axis. And for example, the incisor teeth and the canine teeth, they tend to have a more elliptical shaped canal. And then, the third maxillary incisor as well tends to be more curved. So when you're pulling it, you can't pull it straight. You may have to be pulling it in more of an arc to get a successful extraction. Same thing. Another oddity, or I guess interesting characteristic, is the mandibular molar teeth. So the first mandibular molar tooth on X-ray, you quite often see these two lines on the mesial root, and that is another question that we get asked. What is those two What are those two lines on the mesial root of the lower mandibular molar? And it is because in a lot of circumstances, the mesial root actually has a concave surface, and I don't know how well that shows in the picture, but it's got a bit of a concavity. So that means that those two lines there are actually the two edges of that root that are superimposed. And what the implication of that is when you're putting your elevator down after you've sectioned that tooth, is you do have to elevate along those two edges in order to fully cut the periodontal ligament. The other thing is those teeth quite often have little hooks on the end, like we saw with Copito. So they're dilacerated, and they are a lot more curved than some of the other teeth. In some instances they're nice and conical and straight, like that one. But this little one here is curved. So again, they need to be pulled in an arc rather than straight upwards. And then the second and third molars, you can get variable root anatomy. This is one we saw the other day, which I just really love because it looks a little bit bashful. He's got his little legs sticking out, and he's got root fusion. It kind of looks like he wants to go to the toilet or something like that. And next to his very staunch neighbor, the first mandibular molar. But anyways, if you were to try and extract that tooth, again, you'd have to consider that it's got this big fat root, and it's got that little leg sticking out there, little foot sticking out there. My words got covered a little bit there. That's okay. And then lastly, this just of mention again is the premolars and maxillary molars have a more conical shape. So those ones are more likely to be pulled in a straightforward fashion, and you elevate all around them in a circle to remove them. Yeah, I love the maxillary molars. They're actually some of my favorite teeth. I've decided that, if I were to pick a tooth, I do actually love the maxillary molars a lot. They just look so cute. And also the mandibular molars are cute too. So what happens if we do actually break a root fragment? Well, there's a lot of question about whether the root fragments should be removed, and whether you should or you should have intentional root retention. But most root fragments do actually need to be removed unless they're ankylosed. If there's any form of periodontal disease, they do need to be taken out because they can fester and create a sinus tract or underlying subclinical infection. So the first thing to do is if you break a root fragment, if you haven't already raised a surgical mucoperiosteal flap, now's the time to do it. So raise a flap and remove more buccal bone. And you can often get down to the level of that tooth root fragment and elevate it out. The other thing is if the bone is very, very thick, then sometimes you need to look down and make a trough around the root, at least something that you can seat your elevator into to try and pull that root, elevate around that root fragment and then flick it out with your instrument. So this little instrument here is the Sislak Super Slim Feline Dental Elevator, and it is magical for taking tooth root fragments out. It's got a very, very, very thin, sharp edge, and I used to really like the root tip forceps that have really fine tips on them to try and pull the roots out. But in terms of elevating out a tooth root fragment, this instrument is really, really helpful. So I would highly recommend getting one of those. Now, if you really cannot get that tooth root out and you're concerned about causing more damage to the animal, then, as I said before, there's nothing wrong with stopping what you're doing, suturing it, and then informing the client that you've left a root behind. And most clients are very accepting, and they are much happier that you've stopped rather than causing more trauma, and that you've told them that the root is there and that you can either A, monitor it, or B, send it to somebody who can retrieve that root, or come back at a later date and try and take it out. So again, consider staged procedures. It's perfectly fine to do that. I know that we often are concerned about whether the client's going to come back, or if they're going to consider doing another dental. But in my experience, most people are actually pretty good about monitoring those animals and bringing the patients back if they need to. So when it comes to closure, we go back to basics, and that's Halsted's surgical principles. So Halsted was a guy, I think, in 1800s, and he came up with these surgical principles to try and reduce surgical morbidity. And they do apply as well with everywhere else in the body, just as the same in the oral cavity. I would say probably the ones of eliminate dead space and observing strict asepsis are probably not as useful in this circumstance because it's difficult to do that in the oral cavity. But certainly the first 5 principles we want to try and adhere to. So handle the tissues gently, and using nice fine instruments will do that, and good technique. Minimize tissue tension is probably the most important to reduce post-operative dehiscence, which we'll talk about shortly. You do want to try and preserve your blood supply, so be aware of this when you're making your vertical releasing incisions and your flaps and things like that. You don't want to cross any major vessels or things like that. So that is one thing to observe. And then once you are suturing it, make sure that you have good apposition. So quite often what we'll do is we'll oppose the tissue first to make sure that it's going to close nicely. And if there's still a lot of tension on it, then we'll go back and change and do some tension relieving things to bring that flap down nicer. Again, control hemorrhage. Well, most of the time, if you have hemorrhage, then pressure being placed on that area will stop it. But a nice, well-placed flap will help to support the blood clot and help you control that hemorrhage if you still have some ongoing issues. So again, there's our little guy from before. Well, it's not so little. This actually was a large American bulldog, and he had flap dehiscence, I think, about 4 days after the referring vet had done the surgery. So this flap, unfortunately, was put under way too much tension. So he hasn't there hasn't been sufficient releasing incisions made, and you can see even just from lifting up the lip, there's a huge there's a big gap now where it's retracted, but you can imagine how much tension that tissue was under. So again, prior to closure, make sure that your tissues oppose well. And if you have a lot of tension underneath there, then you want to try and release the periosteum. So that means grasping the edge of your flap, and then running your scalpel blade just underneath the flap somewhere up here, or using your scissors to just sort of blunt dissect underneath there. And that will help to release that flap down. And you may need to extend some vertical incisions, and that will allow it to sit nicely, so that when you pull on the lip, as the animal would do when it's like it's eating, like masticating and other things like that, it's not going to have too much excessive tension on that suture site and cause it to break down. The other thing that can really help is to do an alveoloplasty after your extractions. So whenever we've done extractions, there's always inevitably some jagged remnant of bone or an irregular edge that's present. So if you have any sort of bone spicules, like just run your finger along those extraction sites, and you should be able to see whether it feels rough or smooth. If it feels rough, then take your burr, usually like a little round burr, and just run it along there and smooth out any jagged sites or any bone spicules before you stitch your flap, and that will again assist with avoiding flap dehiscence. The other thing is try and close it with a fast dissolving suture. So nothing like PDS or anything like that, mainly because you want something that will allow the gum to heal without sitting in there causing a foreign body reaction. So fast dissolving suture is good. We use Cephal Quick. In the past, I've also used like monocryl and things like that. So something that will allow the tissues to heal without sitting there for too long is ideal in these circumstances. And again, these are some examples of tension-free flap closures, both with the carnassial teeth. Again, a well-placed flap leads to improved healing, and it helps to control any hemorrhaging by supporting the existing blood clot that's there. So I would love to talk about more and more of the complications and things like that, but we're reaching the end of the lecture now and the time that I've got, and hopefully it's been helpful. I just thought I'd just end with a case that I again found a really big learning experience for me, that we saw this year, and this is just to illustrate how beneficial appropriate training, diagnosis and planning when you're dealing with a cohat is when you're trying to achieve a successful outcome. So this is Ruby. She's an 11-year-old female spayed Cocker Spaniel, and she's had quite a bit of dental work done in the past, but she still has periodontal disease. So that's what she presents for, is for periodontal disease. So you can see that she's missing quite a few teeth. The teeth that are remaining are in varying stages of periodontal disease. Some are healthy. Well, a few are healthy, and then the others are not so much. Okay, so then one of the examples is that she has got this palatal flap, again, similar to the Dachshund that I was talking about earlier, if any of you guys were here lingering around before the webinar started. So there's alveolar bone loss just on one aspect of the root, which is the palatal aspect, which is quite common in dolichocephalic dogs like Dachshunds and Greyhounds, but can occur in other breeds such as Ruby. So she's got a little pocket, probably around 6 millimeters there. And the other thing too is she's also got a class 2 malocclusion, so she's got an overbite, and she's got lingual version of, or she's got lingual version of that lower canine tooth, meaning that it's more vertical. So rather than sitting more labial, that tooth is too vertical, and it's actually penetrating into what was previously a third incisor site. But the third incisor somewhere along the way was removed, probably because it was diseased from that tooth contacting it. But once that tooth was removed, there's nothing to stop it from penetrating directly into the soft tissue. So now she's got an oronasal fistula as well. So then we take dental radiographs, and she's got a nice growing problem list that we have to plan around. She's got furcation exposure and bone loss around some of the teeth. She's got retained tooth root remnants in several spots that actually have got a little bit of gum reaction over top, meaning they need to be addressed. She's got periodontal disease, advanced periodontal disease of some of the incisors, and this is also adjacent to that big oronasal fistula. And then you can also see that infrabony pocket, which is the vertical bone loss along the palatal side of the canine tooth root. So Ruby's problem list, she, again, when we look at it, she's got the class 2 malocclusion. She's got a linguoversed left mandibular canine, which is causing an oronasal fistula of the adjacent third incisor site. And she's got periodontal disease of various stages, including a palatal pocket associated with the right upper maxillary canine. She has also got retained tooth roots. Now, these owners are very committed, and they want to try and save the principal teeth if possible. But they're not too worried about things like the premolars and incisors and things like that. But they do want her to try and save her remaining canine teeth. So this is her treatment plan. And again, this is where we're trying to plan strategically to avoid complications. So she needs a crown reduction pulp capping of that linguoverse canine. She needs extraction of the teeth with advanced periodontal disease. We want to do open root planing and synergy placement, which is that bone graft, synthetic bone graft placement into the palatal pocket of the right maxillary canine tooth. We need to repair the oronasal fistula under tension-free closure. You need to remove the retained tooth root and then clean any remaining teeth that are left, which might be only 3 or 4, but they still need to be cleaned. So so it's quite an extensive treatment plan here. But when we have this all in hand, we can talk to the owner exactly about what we need to do, how much time it's going to take, and what the follow-up is going to be required in order to avoid any complications along the way. Okay, so there's Ruby afterwards. She's had some of those diseased teeth taken out. She's had a nice scale and polish performed. She's had the oronasal fistula fixed, and she's also had the crown reduction and pulp capping of that lower canine tooth. So she goes on. She's come back regularly for follow-ups. The owners are doing very, very well, taking care of her remaining few teeth. And, this is a successful outcome that's come from accurate diagnosis and treatment. And there's a final x-ray just to show you guys of the synthetic bone graft being placed. So there's the bony defect again along that maxillary canine tooth, and then there's the synthetic bone graft that was placed in there, and that just helps to retain the alveolar bone height of that tooth. All right. So if, any of this has piqued your interest and you want to find some really good resources on how to perform extractions, I would highly recommend you go onto the Foundation of Veterinary website, the Foundation for Veterinary Dentistry website, and look at their compendium bundles. So I was showing Simon this earlier, but these have really good step-by-step on how to do a lot of the surgical extractions. For example, I don't know if you can see here, this one here is the surgical extraction to the maxillary canine tooth. So they've got beautiful pictures and diagrams, very, very helpful. And they've got a whole bunch of different topics that are in there as well, from periodontal probing properly and charting, and interpreting dental x-rays and things like that. And you can see, this is in US dollars, but it's not too expensive. It's quite affordable, and it is actually a really lovely bundle to have. There are also other dentistry textbooks. There's one by Frank Verstrati that also discusses exodontia or extractions. So I would recommend looking into something like that. And then if you want to go meet other fellow dental geeks and just immerse yourself in everything dental, I highly recommend you come along to one of the veterinary dental forums. This is in the United States. They have it every single year. And the first time I went, I was like a kid in a candy store. I was like running around from one lecture to the next. They've got awesome wet labs. So if you love dentistry, try and save up and come to these one year. It's really worth it. And if you happen to be coming, just message me and let me know. And there's usually a New Zealand and Australian contingent there, so we can go around and yeah, just make more fellow dental geek friends. All right. So that's me for tonight. Hopefully that was all right, and you guys enjoyed that. And I'll let Simon.
Thank you so much, Crystal. That was absolutely wonderful. We really enjoy your enthusiasm. Those were excellent cases, some very gruesome pictures. I'm going to have nightmares tonight about ophthalmic trauma during extractions. But we really, really appreciate this, and I think that has been very, very helpful to everyone. So now's the time for questions if you've got them. I'm also going to put up the quiz. This will allow you to double your CPD points. So have a go at those. We'll leave that open for a while. I see all the thank yous coming in. That's very, very good. We do appreciate you spending your evenings with us on these lectures. The recording will be available for your colleagues who weren't able to come in tonight in about a week or so. We'll send out the link online. But if anyone has any questions for Crystal, now's the time to go.
Thank you guys all for attending, by the way. And yeah, shout out to David, who's here, my amazing mentor. So he's, he's probably the most important person in my dentistry career that's really ignited my passion. So everyone say hi to David as well. Thanks for the support.
Thank you, David.